they spread, and they invade. So multiply, we call proliferation. They multiply much faster than normal cells. If you cut your finger, you will heal because your skin will grow back, the muscle will grow back. Cancer cells grows much faster, so it doesn't heal in a linear line, it forms a bump. So that is proliferation. It then invades. That bump not only just comes to the outside, but also it invades to the inside. That's what we call invasion. And then metastasis or spread, it goes to the bloodstream and the lymphatics and spreads outside. So for example, often I hear, well, my mother had breast cancer, but she died of liver cancer. Well, that's not quite true. The breast cancer from the breast spread in the breast, into the lymph nodes, into the bloodstream, and then to the liver. So what you find in the liver in that particular patient is a metastasis of the breast. So if you biopsy the liver in a patient with breast cancer, those cells look exactly like the breast cancer tumor. So what is cancer? It is a proliferation, fast-growing cell that invades and then metastasizes. And if you look at it, the most common cancer for women all over the world today is breast cancer. In Uganda, it seems to be cervical cancer, but cervical and breast cancer will sort of swap positions, number one, number two. In men, it's prostate cancer and esophageal cancer, which is the upper part of your digestive system where you swallow your food. So overall, that is cancer. And the fear about cancer is the fact that we believe nobody can stop it. So we are in a way afraid because we are in a way helpless. We believe anybody can get it and there's nothing to protect one. And we believe that there is no treatment for this. And all three beliefs are not quite right. We can do something about protecting ourselves against cancer. We can detect it early in a variety of cases and increase our chance of cure. And even when we have cancer, we can cure it in a number of ways. And often we may live with cancer just like we live with diabetes. So that in a nutshell is a big scope of cancer. And I'm happy to answer any specific question that we can go into about the specifics for women, for men, early detection, etc.
Thank you very much, Professor. Professor, what is to metastasize? It's a term that we hear so much. How would you explain it simply for someone to understand?
Yeah. Metastasize means when the original tumor spreads to another organ. So as I explained, if a woman gets breast cancer, it will metastasize to the lymph node under your arm, under your armpit. So that is a metastasis. From there, it might invade into the bloodstream and go wherever the blood takes it. It may go to the lung. So all of a sudden, breast cancer has now metastasized to the lung. So when you think about it, the best way to cure breast cancer, as the example I took, is you detect it early, and the best way to detect it early today is mammography. Every woman above the age of 50 should have a mammogram because that is the age when we start seeing more breast cancer. If you pick it up early, before it has metastasized to the lymph node under your arm, the cure rate is 90%. If you pick it up when it has spread to the armpit under your arm, then the cure rate drops to 60%. If it has metastasized to another organ, the cure rate drops to 20%. So you can imagine mammography is the best way to detect breast cancer early before it has metastasized. And when you remove the breast, taking care of the primary tumor. And in case some cells have spread, one can give some treatment for those cells that have been spread. So metastasis is spread of a tumor from the original organ to another organ beyond its confines.
Thank you very much, Professor. I would like to ask Miss Diana Namuviru Sewanyana. Could you please give us some of the common cancers as statistics within Uganda as a public health officer?
Oh, thank you so much, Adrian. I'm definitely excited to
Dear,
catch you there.
Diana, sorry to cut you short. My request is if all the panelists and the moderator could switch on their videos, please, in case it's not inconveniencing. Thank you.
Yes, Dana.
Sure, I hope you can see me there. And
Yes, we can see you.
Oh, beautiful. I'm definitely delighted to catch Rotarian Adrian there and Rotarian Chove. I think those are the two people that I am familiar with online this morning. And obviously, I'm delighted to have my colleague, Professor Mansour, online this morning. So obviously, even before I step into responding to your question, I would like to appreciate the Rotarian Club of Ntinda for putting this together. And I think it is a noble cause. It is a right step into the right direction to deal with the subject that we're tackling this morning. And so to back into your question, Adrian, what we are seeing statistically, I know obviously Professor Mansour will give you better figures in this area, but what we see in Uganda is, for example, we were looking at studies just yesterday, looking at what is going on in the country, and we got to realize that, for instance, Uganda Cancer Institute receives about 4,000 patients annually. These are newly diagnosed cases. And many of the cases that we see at Uganda Heart Institute, or even in our centers that come through, we're looking at breast cancers, we're looking at prostate cancers, we're looking at cervical cancers. Mainly, those are the commonest cancers that we are seeing in Uganda today. And that is not any different from probably what is seen in Kenya and elsewhere across the globe. So what we're dealing with in Uganda is not very peculiar to just us, but we see the same exact picture copied and pasted globally. And obviously, Professor Mansour is going to continue to take us through exactly what is seen, say, in Nairobi, in the rest of the world. And we will pick it up there. Over to you, Rotarian Adrian.
Thank you very much, Diana. Back to Professor Mansour. What are the trends of the cancers lately, globally and in Africa?
So let me add to where Diana took off. 1 in 5 individuals will develop cancer in their lifetime, 1 in 5. So it used to be that the most common cause of death was heart disease, diabetes, cancer. Today, cancer is superseding heart disease and diabetes, not just here in Africa, but all over the world. On the other hand, we in Africa are now developing certain habits which we adopted from the West, and we are adopting some of their pathologies. So if you look at the 3 risk factors that are universal that promote cancer, one is obesity, diet, and lack of exercise. And I'll try to explain to you why. Obesity, the more fat we have in our body, the more estrogens a man and a woman will make. Estrogens are a growth factor for breast cancer. Estrogens are a growth factor for a number of cancers. So as you become obese, your tendency for cancer rises. Obviously, your tendency for heart disease rises, the tendency for diabetes rises. Diet. If you look at the Japanese who eat significant fried, grilled food, their biggest cancer is oral cancer, esophageal cancer from the food. I see a lot of patients here in Nairobi, and I'm sure it's the same thing in Kampala and in Uganda, with esophageal cancer because of our diet. Either it is food that is very grilled in some way, nyama choma, etc., or we may be indulging in drinks, alcohol, etc. They may be brewed at home or somewhere else that have carcinogens. So you can see the diet impacts us significantly. More red meat, not good for you. So as we become very Western in our diet, our risk factors for those cancers that are very Western oriented become high. So if you looked at the Japanese population, when the Japanese immigrated from Japan to Western part of America, their gastric esophageal cancer rates went down because they were no longer eating teriyaki, etc. On the other hand, they became more obese and their rate for colon cancer and breast cancer went up. So you can see the migration leads to change in diet, decreased exercise, high fat content, and the same thing is happening to us here in Africa. So if you look at the numbers, breast cancer rates are going up, cervical cancer a little bit down, not very much down. Why? It is interesting. When I ask my patients, do you think cancer, you can vaccinate yourself against cancer like against COVID? Says, no, you can never. And the truth is, yes. The most common cancer, number 2 common cancer in women is cervical cancer caused by the virus HPV. You can vaccinate against HPV like you vaccinate against polio and smallpox. If we in Africa were to vaccinate our young boys and girls from the age of 13 to 16, we would eradicate cervical cancer by 96%. Yet, only 10% of young boys and girls in their adolescent in Africa get vaccinated because of either lack of vaccine supply or the expense. So you can see we can eradicate one of the most biggest surges of cancer in Africa, cervical cancer for women, save lives, save the lives of mothers and children. But we've not been able to do that. Number 2, what about breast cancer? If the federal government, both in Kenya, Tanzania, Uganda, would say mammography is free for anybody above the age of 50, we would reduce the risk of breast cancer and increase the curage of breast cancer by nearly 70%. If the federal government in East Africa said for every man above the age of 50, the PSA test, which is a test that shows prostate cancer, is free of charge, we would reduce the risk of prostate cancer by 80%. Well, imagine the quality of life and the economic power that we can get if we save those men and women. So when you talk about the trends are getting worse. Our ability to early detect is getting less because we don't have kind of funding. And as a result, we lose lives. And then it comes up to me, the oncologist, to give chemotherapy, radiation, etc., things that people do not like. But we can avoid many of those if we have awareness, which I hope Rotary will promote, early detection, which I hope Rotary promote, and the federal government would support. And then I think we could really decrease this morbidity, mortality of this really dramatic disease, which is on the rise in Africa.
Thank you very much, Professor Mansour. Like I can highlight in the immunization of HPV, I think while we're waiting for the government to intervene, I would pick a leaf, the Imat of Uganda, the Agha Khan Foundation. They immunize their girls as a unit. I think the Rotary Club and fraternity can pick up on that to get our young girls immunized and boys, and also to encourage more men to do PSA tests. Professor Mansour, what are the new developments in management of cancers, the common cancers that we see?
So that's a good question. As I said before, if you can pick up the cancer before it metastasizes to another organ, your cure rate is improved. So let's do early detection, mammography for breast cancer, a pap smear for cervical cancer, a PSA test for prostate cancer. You can have a colonoscopy for colon cancer. So the number of tests that the Uganda Cancer Institute puts out is early detection. So let's hope that we do that, because if you detect early, the chance of cure is much better. Let's say you are at the part of early detection, you have a lesion, a tumor in the breast, in the prostate, in the colon. The first thing is obviously to see, has it spread? And to do that is you do a physical examination and you do a CAT scan. The CAT scan will tell us, or a PET scan, and I'll explain to you what a PET scan is. A CAT scan or a PET scan will tell you, has the disease spread anywhere else? So that's a good piece of information. How big is a tumor? That's a good piece of information. Then we biopsy this lesion to say, what kind of breast cancer is it? And it gets a little bit complicated. Some breast cancers are hormone responsive, so you can treat them with anti-hormone. Some breast cancers have no receptors, no hormone receptors. We call them triple negative breast cancer, very aggressive. Those require chemotherapy to treat. So biopsy is number one. If there's no spread, surgeon comes in to resect the tumor. Now remember, not any surgeon, every surgeon is a breast cancer surgeon. We have to specialize ourselves. When a general surgeon removes the breast tumor and leaves cells behind, the risk of recurrence is very high. So we have to have a negative margin around the tumor to be able to be sure that we took it all out. And then the pathologist will tell us, yes, you took it all out with a negative margin around the tumor. In the case of breast cancer, you also have to remove the lymph nodes in the axilla under the arm to say, has the cancer spread there? Yes or no? Often, we don't have people removing those lymph nodes in a proper way. And we say, I took it all out. Well, you didn't. You did not take out those cells that have spread to the axilla, which is the cause of further spread. So surgery by a trained surgeon is the first action. If there is spread, then we may have to be able to use radiation therapy for local control because radiation irradiates cells within the vicinity. And if there's a risk of spread outside, we then use chemotherapy, immunotherapy, etc. So the three main tools against cancers are surgery, radiation, chemo, immunotherapy. But the best protection against cancer, I keep on saying, is early detection. And let me explain what is a PET scan. When you do a CAT scan, it's like an X-ray. It looks at the lesions that you will have. We can separate the organs of the body. And when we see a tumor, it looks differently in the breast, looks different in the colon. So we can pick up this lesion. We can also see the lymph nodes. We can also see whether these lesions have metastasized elsewhere. So that's a CAT scan. A PET scan is when we give you intravenously radioactive glucose. So we give you radioactive glucose. Any part of the body that is spreading or growing rapidly will take up the radioactive glucose and show up as a hot, red hot spot. So if there is a tumor in the body that is proliferating, as I mentioned before, growing very fast, it will take up a lot of the radioactive glucose. It shows up as a red hot spot. And if I could have shown a picture, and if I'd known before I could have done it, I could have shared a picture of a PET scan. It shows you all the places in the body where the tumor has spread, which are red hot. The brain takes up glucose every time because every time you think, you're taking up glucose. So the brain is red hot as well. So in fact, we've done studies where if you meditate and do a PET scan, your brain will become less hot because it's very quiet, not thinking, and the consumption of glucose goes down. The consumption of radioactive glucose goes down. And on the PET scan, it goes from red to orange to very dull tan. So that's what a PET scan is. But the modalities to answer your question is surgery, radiation therapy, chemotherapy, and then we can talk as we go along. What is immunotherapy? Immunotherapy, we have an immune system that is supposed to fight anything that invades us, COVID, HIV, etc. In fact, the reason HIV spreads so rapidly is because it infects our immune cell. It infects the T cell, which is the most potent cell in our body that fights infection and pathogens. So when you, in a way, infect the T cell, destroy the T cell, you become T cell deficient, and that is why HIV patients develop other cancers. Kaposi sarcoma, cervical cancer, infection, opportunistic infection, things that you and I may not get because our T cells are intact. So T cells are very important. Now, in terms of cancer, the cancer can camouflage itself as it is part of self. So the breast cancer tumor will camouflage itself to look like breast cells. So the T cell in our body says, well, this is not a foreign cell. This is like the breast cell, so I should not attack it. More importantly, the breast cancer cell emits certain hormones to sterilize our T cells. It's a very smart tumor. We've discovered these days that tumors emit what we call cytokines that block T cell activity. So our T cells now become in a way, sterilized, in a way they put into a sleep state so the cancer can spread. So immunotherapy is a treatment that activates our T cells. So there are a number of drugs today that are not like chemotherapy that make you lose your hair, nausea, vomiting, dropping your blood counts. These drugs are meant to activate your T cells to overcome the sterilizing effect of those cytokines produced by the tumor. So I think if you come to me today for a variety of cancers, one of the treatments I will give you is immunotherapy. And that is to augment your own T cells so that your T cells can fight your cancer.
Thank you very much, Professor Mansour. When we talk about cancer, things like affordability will start coming in. I'd like to go to Diana. Tell us about the financial accessibility and affordability of cancer treatment in Uganda.
Okay, thank you, Adrian. That's a very pertinent question, I think. And I think everybody out there is probably concerned about the cost of care for cancer across the country. And I must say, having practiced in this very country for quite some time now, I can tell you that one of the biggest challenges that we are facing in the management of cancer is actually the financial access. Forget about the physical access, because right now we have quite a number of centers that are attempting to do this. But the aspect of financial access has continued to be of significant importance, in as much as we see that our government has clearly subsidized and made it accessible and affordable, especially through the Cancer Institute. We still see people that cannot afford to access cancer care across the country. And that is mainly because most of the treatment that is used in the treatment or in the management of cancer does not necessarily come cheap. And because of that, we have continued to see many Ugandans actually lose their lives, not because their cancer has probably been detected late or not because they've not been compliant to treatment, but because of the aspect of financial access to healthcare. Now, in Uganda, we are living at a time where most of the Ugandans that are accessing healthcare have either an option of private health insurance, or they're going to pay out of pocket, or they're going to go to the government facilities where we can access services at a very, very subsidized rate. Now, given the challenges that we have, especially with private health insurance, which sometimes is discriminatory when it comes to taking care of financing cancer, particularly, many at times we have seen people that have had cancer, they have insurance, but they will still not be able to financially access because for one reason or another, maybe it is not covered under the insurance, or the treatment has gone beyond their provided ceiling, and therefore they cannot afford. And that has grossly contributed to the many challenges that we experience in the management.
Diana, we can't see you.
You can't see me.
Yeah, we can see you now.
See me now? Oh, sorry about that. So clearly speaking, what we are looking at as a country is the financing gap that is existing between the providers and those that are seeking the healthcare in the area of cancer. And as thus, at the Agha Khan University Hospital, we are coming out particularly to complement what is already existing in the nation, and that is to provide subsidized care for cancer management, and that is going to probably come around in the market somewhere next year. We're trying to see how we can gradually introduce remedies at an affordable cost to the many people that probably don't have insurance, or they have insurance, but it's probably not adequate enough to take care of this, or even to reduce on the cost of care for the people that seek healthcare outside Uganda. And I think that has probably been on the hearts of many Rotarians. We have seen you get out of your way to fundraise, to make sure that you're buying the equipment that you're buying within the country. We have learned about your involvement with, say, Zambia Hospital to buy a linear accelerator, for example. That is one of the right steps into the right direction. When we have some of these equipment within our country, then our people will be able to afford the healthcare that they deserve. And that is why we encourage and we support and we celebrate institutions like Rotary Club for putting together monies to help the people that cannot afford. And just beyond Rotary, our contribution as the Agha Khan, we will not just stop at providing the healthcare, but we're also going into the space of education. We'll be teaching people, we'll be having a teaching university very soon within the country, where we will be equipping people, we'll be giving out knowledge so that people out there away, say from Kampala, people that cannot go to Nairobi, people that cannot go to India, can actually access a quality care away from Kampala at a rate that is substantially affordable. And so yes, Adrian, just to answer your question, financial affordability is a big issue, and we are seeking, we are partnering, we are working together to complement whoever is putting something in this space to make sure that cancer care is affordable and accessible. Thank you.
Thank you very much, Diana. Professor Mansour, just this question, you've been practicing all over the world and you've seen trends with Africa, where we've come from infectious disease, where we've had a high burden of infectious disease, and now we're getting a high burden of non-communicable diseases. In your view, as a professor, a leader, a practitioner, do you think the African society is ready to tackle the increasing rate of non-communicable diseases?
In many ways, we have no choice if you want to be realistic. You know, AIDS came and disseminated all our young men and women in incredible power, brain power, monetary power, human resource. And today we have treatments. We live with HIV and we have productive lives. Obesity, hypertension, diabetes takes care of a number of our talented population. That is a surge and a scourge as well. Cancer to me is one of those that is on the rise. And we have to have a commitment as a government to say, this is just like any other major enemy. If we were invaded by some country, I can assure we would put our arms and say, no, you can't. This is our country. We would really amass our resources, our people, our ammunition. Cancer has to be fought like an enemy that is coming into us and attacking us. President George Bush in the US says the war against cancer. We have to deal with it like that. And my feeling is, one, we, leadership, civil society, Rotarian clubs who have influence around the world in the countries in which you live, have to be able to really approach the government to do one thing. One, as Diana talked about, if you cannot pay for expensive medicine, at least pay for early detection. Because if you did that, our rates of cancer would not go down, but we'll pick them up early. Treatment early is much cheaper, much beneficial, higher cure rates than treatment late, number one. Number two, make awareness part of a public service, whereby women and men who have cancer, I see women with breast cancer who've been waiting on this tumor for months and sometimes even years. Go to the local Nganga and he says, give you this, give you that. And by the time they come to me, it is widely metastatic, uncurable. That is a travesty. So awareness is very important. And I think all those things could be done, but it will require an active effort by the government, active effort by civil society, Rotary being one of them, to say, yes, we can, yes, we should, and we must. In the chat, there have been some questions about prostate cancer. You know, the most common cause of death in men in terms of cancer is prostate cancer. But as we grow older, the prostate becomes larger. It stops us from passing water freely. But that's not prostate cancer. That is benign prostatic hypertrophy. So that is separate. There were questions about any causes of prostate cancer, watermelon seeds. No. The Only things we know that cause cancer is high fat, low fiber, lack of exercise, because it increases certain hormones that promote cancer. Viruses. The HPV virus causes cervical cancer, causes head and neck cancer. They also cause rectal cancer. And there are a number of other cancers, viruses that we are detecting today that are contributory to cancer. For example, COVID does not cause cancer, but when COVID suppresses your immune system, the T cells that I talked about are now suppressed. So any tumors that you might have that could have been eradicated and now are free to metastasize. So anything that helps your own human health, good diet, exercise, low fat, high fiber, all that is very helpful.
Thank you very much, Professor Mansour. You've talked of high fat, high diet, and I think if you've noticed how Africans, our trends are changing, that obesity is increasing in many of the communities we are growing in. Back into management of cancer, what are the multidisciplinary way people would have managed cancer? For example, if you are managing a person who is ill with cancer, what could be the best way you can approach in managing them?
So I'll tell you what we do at AKU in Nairobi, which will be the same thing that we'll do at Agha Khan Hospital in Kampala as we grow our program. Because in Kampala, we will have a hospital, first phase, 150 bed. We'll have an outpatient clinic. We'll have a cancer clinic. We will work together with Malago Hospital, with the Uganda Cancer Institute, with the Fred Hutch Cancer Center to collaborate, to work together, a public-private partnership. You ask about management. For example, we at AKU in Nairobi, and we'll do the same thing in AKU in Kampala, are the first ones who have a multidisciplinary approach. So for example, if you come in with a breast mass or a difficulty with urination, we will examine you. We'll do a mammogram for a breast or an MRI for the prostate. If we see an abnormality, we will biopsy the breast or biopsy the prostate. If it is cancer, we present your case to the multidisciplinary tumor board. So there's a surgeon, the urologist, the pathologist, radiologist, oncologist, everybody. We provide theoretically the best option for this particular patient. So it's okay, surgery or radiation or chemotherapy. And then we go above and beyond that. Pro bono, we call the patient in. The surgeon is there, the oncologist is there, the radiation therapist is there, the nurse is there. We meet with the patient and tell them, this is the journey we believe is the best for you. Let's take an example of breast cancer. Your tumor is so big, let's shrink it down with chemotherapy, and then you'll go to surgery because then you can conserve your breast. Because we want to conserve your breast, we'll have to give you radiation therapy to the rest of the breast that was not taken out because we only took out the tumor. And by the way, if it has spread to the lymph nodes, we will then give you chemotherapy. So we are there right, all the consultants are there right with the patient is there with the family, we can ask the questions. That multidisciplinary approach is very, very critical. So that is the beginning of the treatment journey, because often the surgeon says, I took it all out, it's done. The patient feels it's all done. Well, that's not true. There may be still cells left behind. You may have to go for radiation, you may need chemotherapy. Explain to the patient from the get-go what their journey would be, allows them to understand the risks, the benefit of getting through this process. And to help them along the journey, we have trained nurse navigators who will help make sure they are compliant. You asked the other question about what about the end? There are cancers that clearly have widespread, incurable, and for whom we have no treatment. There we have a very sophisticated palliative care program, a supportive care program. We come to your homes to provide pain medication, oxygen, comfort care, etc. So both ends of care, upfront curative intent, end of life palliative care, where we really provide dignity of life even at the end of life. That continuum is part of oncology. And that is what we do here at AKU in Nairobi, as other hospitals do as well. That's the same philosophy we'll adopt when we have our university hospital in Kampala.
Thank you very much. Then this will be our last question. When are we expecting that teaching university hospital His Highness promised years ago?
Oh, that's a good one. That's definitely a good one from you, Adrian. So we definitely have some timelines that have been laid down for the expected date for this mega project. I really must say, and I've had quite a number of comments in this particular space from many of the well-wishers and people that have been waiting to see this dream come true. The expected date, we probably won't give you the exact date and say maybe 1st September 2022, no. But we know that we have set timelines in place, and we're definitely not looking anything beyond 3 years from now. And we definitely are coming from a point where a lot has been put in place, especially to prepare for the upcoming of this hospital, because there's so much that is involved, like Professor Mansour has put it. We are looking at having a teaching hospital. We are looking at having a tertiary care hospital. We are looking at moving right from primary healthcare into tertiary, and therefore that is not definitely going to take us a very short time. Quite a number of years have been put in place to look at the feasibility studies, just to understand the market, to understand the disease burden, to understand the resources available locally to actually manage such a level of a hospital. And that has been already put aside. So we are in the stages, we're moving forward. For instance, I must tell you right now, the construction has already begun for the academic building, and we expect that that should be up and running in about a span of 2 to 3 years from now. We already have a facility on ground that should be beginning operations somewhere after first quarter of next year, while we will also be doing cancer management in that facility. It's going to be sort of like an outpatient facility that will kickstart off the management of some of the conditions that we are having taking on Ugandans. So we know that by first quarter of next year, we will at least have a primary healthcare facility on site at Nakawa. And even as we open up that, we will have the academic building continuing to go up. And while the academic building is going up, we'll also have the hospital construction happening. So we are looking at a span of, say, 2 to 3 years for us to have exactly our dream come true. I don't know if I've answered your question. I know you definitely wanted timelines, but that is what we can say, given the conditions that we're working with.
Yes, then take us through a simple process if someone wanted to refer to Agha Khan Nairobi through Kampala.
Sure. So in Kampala, the Agha Khan University Hospital currently operates 3 medical centers that we tend to refer to as outreach facilities. All these centers are very well equipped to pick up cancer cases, for example, in the very early stages, as Professor Mansour has told us. For instance, we are able to do the early screening. If you're talking of PSA or you're talking of pap smears, these outreach facilities are able to pick up some of these cases. And once these are identified, obviously we go through the normal treatment. We have quite a wide range of panelists in this area that actually take care of our patients locally. And once we fail, for instance, if we have a patient that requires to go to Agha Khan Nairobi for one reason or another, they can't get what they probably need in Kampala, and therefore there is need to go and see our oncologists in Nairobi. We assist them through our medical centers. We've done this with quite a number of patients so far. Our latest has probably been, I think, a week ago. We send them through our system. We have a patient referral desk that we are directly in touch with through our clinics in Kampala to the patient referral desk. We connect them through, we assist them into getting tickets, into getting to see the oncologists on time, if they need accommodation within the hospital or outside the hospital premises, especially those that are just going in for chemo that don't really need admission. Our team, our patient referral team in Agha Khan Nairobi is constantly in touch with us and with those patients to ensure that they get everything they want from the point of detection through the point of treatment, through the airport transfers from Entebbe to Jomo Kenyatta into Agha Khan Nairobi. And even after treatment has been given in Agha Khan Nairobi, we also have a team that is resident in Uganda for continuation of care. So once the doctors in Nairobi have treated the patients and they feel they're good or well enough to come back to Kampala, then they will come to our centers, continue with the course of treatment that has been prescribed in Kenya. Some of the patients actually go to Uganda Heart Institute. We have seen collaborations with Kampala Hospital, Nakasero, International Hospital. Many of these oncologists are working together with us as a team to ensure that the patients receive the best of care in the most efficient way. So we're not working in isolation. We are not a standalone facility. We are a team of people that are working together to ensure that our patients receive the best that they possibly can be.
Thank you very much, Dana. To wrap this up, I think Professor Manzur, could you just take us through as we wrap this 1 minute, Professor?
So I think if there was one message, one is early detection. You have to be aware of your body. When you feel something is not right, go and see a physician. You might feel it's an expensive trip, but that is most important. If you're a woman above the age of 50, a mammogram is important. I keep on saying on Valentine's Day, which is past, rather than a husband taking the wife to a dance and a dinner, etc., give her a good gift certificate for AKU Kampala to get a mammogram. That will save that woman's life. On Valentine's Day, when you are being taken by your wife to a good place for dinner and dance, let her give you a gift certificate for a PSA, so you can come and give you a PSA test. I think that should become a Valentine's Day project for the Rotarians for life-saving purposes. So early detection, very important. Number two, once you have an early detection and there is pathology detected, go to an expert. Go to an expert who is qualified in the field, be it heart disease, be it diabetes, in cancer, certainly we are one of those, and then get the appropriate treatment. And I think let's all work with our federal governments to impose the thought that this is an enemy invading us. We have to take this seriously as a war against cancer. And it can be won. It just requires determination, civil society engagement, and what you're doing today is exactly what is required.
Thank you very much, Professor. And one Rotarian is suggesting for Valentine's, a pap smear would do very well for the ladies. Over to you, President. We close our panel. Thank you very much, ladies and gentlemen, for listening to us.
Thank you very much for a job well done, Rotarian Adrian. And thank you, our presenters, for taking us through this very, very, very important and crucial topic. Let me ask the Rio Body Group, Rotarian Chove, who is passing the vote of thanks.
President Caesar, before we do that, I've seen a couple of questions flying in the chat room. I don't know what your stake is on responding to them. Then number two, okay. Personally, I would love to know more where I could find these Agha Khan facilities in Uganda. I don't know where they are, and probably if they do screening. That is only my question before we move on.
Okay. If you can do the questions in just 5 minutes, please.
Right, Adrian, should I pick it up or you can do it?
You can pick it up, Rotarian Chobe. Thank you very much.
All right. Thank you so much, Professor and Diane. And I've been following closely in the chat room. Most of these questions have been responded to. For example, how long does it take? How often should a person test for prostate cancer, and what is the most accurate and available test in East Africa? Professor, can you take note? What are some early signs of prostate cancer? People are so much concerned about prostate cancer. Then how long, this is a good one, how long does it take for cancer to metastasize? Okay, forgive my English, it is not English. Metastasize, okay, Juliet. I don't know if I have the right pronunciation from the time it is detected. I think Robert, I'll wrap it up with Robert's question. Professor Mansour, what should be the regularity of the PCA test for men? Patient involvement, very key. how can a man become aware of changes in their body that they would suspect the irregularity in their prostate? What is the primary functions and location of lymph nodes? David, Jackson, kindly. Professor and Diane, thank you for this in-depth informative session on cancer. So that is it. And my question personally, which I asked if we could get the locations and if you do cancer screening. Briefly, in a period in about 3 to 5 minutes. Over to you, Dr. and Diane. I think we start with the Professor.
So let me just refer you to, if you go to the American Cancer Society, put cancer screening, it gives you a whole list of what tests to do when. And you can even go to the Uganda Cancer Institute. They will link you up with the American Cancer Society. So all of us with access to a smartphone or computer should do that. It'll tell you exactly when to have the PSA, when to have the pap smear, when to have the mammography, et cetera, et cetera. That's number one. People ask about HPV. HPV is a virus, very much like COVID, and you can vaccinate against that virus. That virus infects the cervix, causes cervical cancer, can infect the oral cavity, can cause head and neck cancer, can infect the vulva and the lower rectum, that can cause cancers of those organs. You can vaccinate against that, but that has to be done just like smallpox, polio, mumps have to be done early on. So if you have young children between the ages of 13 and 17, 2 doses of the vaccines for HPV provides cure, protection and cure for those cancers I mentioned. Lymph nodes are those things under your throat. When you have a cold and when you put your fingers under your throat, you feel like these little glands. Those are our soldiers. Those are like the ascaris who protect you. An infection comes down your throat, the ascaris will be swollen, fight that infection at the same places where cancer can metastasize to, and our lymph nodes will attack that cancer. But the trouble is, when they overwhelm the lymph nodes, they can go to the bloodstream and go to other organs, which is why when we do cancer surgery, we remove the tumor as well as the lymph nodes to detect, has the tumor metastasized to the lymph nodes? If they have, then there's a risk that it has gone beyond, and that's when you have to have chemotherapy, radiation. So in general, if you go to the American Cancer Society or UCI or Fred Hutch, it'll give you all the information you need. The main thing is it's available to us. And one of the chat members says, Dr. Ari here has not known how to celebrate Valentine's Day. You can be sure I have had my share of that. I've had my share of gift certificates for PSA, not for the pap smear, but I do know how, but I'm sure Africans celebrate Valentine's Day much more exuberantly than we do in Alabama. So I give it back to Diana.
Thank you so much, Professor. And obviously, that was a very good way to sum it up. Thank you, Rotarian Chobe, for the questions that you have raised. I'll quickly go into the question that you gave me on locations of our facilities. So I said earlier that we currently have about 3 locations in Uganda, and the very first one is where I'm seated right now. This is at the Acacia Mall branch. So if you come to the Acacia Mall, we are located on the 2nd floor. We definitely offer screening services that include PSAs, the pap smears, the breast scans in the Acacia branch currently. We also do some tumor markers, by the way, for anybody that would want to do any of those tests. And just for the Rotarians to note, we do extend these services even to communities away from our reach. So if the Rotary Club of Ntinda would like to have the screenings done, we are available. You could easily contact us. We can come and camp wherever you are, take off the samples, and even give you an in-depth, maybe a full day session just for you to get an understanding of exactly what the cancers look like and how we can easily detect. The other location that we have is at the Metroplex branch. This is in Nalia on your way to Namugongo. The old Metroplex mall that has been renovated has one of our branches right in there, and we can still do the same exact tests that we do at the Acacia Mall branch. Our 3rd branch is located at the Diamond Trust building. That is along Kampala Road on the Diamond Trust Bank building, right on ground floor. We have our doctors there, we have our pathologists there. They're able to take off these samples to do an early screening. I did also mention somewhere that we will be having another branch coming up very soon at our Nakawa site, which should be operational after the first quarter of next year. At this particular branch, we'll be also able to do mammography, we'll be able to do CT, we will be able to do most of the non-invasive tests that will enable our people to do early detection so we can intervene on time. Thank you, Rotarian Chove.
Thank you so much, Diana. And I think I'll ask Rotarian Sylvia Marietta to give us a brief vote of thanks. Then we'll hand over to Caesar, President Caesar. Over to you, Marietta. Marietta, if Marietta is not on call, our very own charity, CMP charity. Marietta is
Sorry.
on.
I am on call. Can I go ahead?
Please do.
On behalf of Rotary E-Club of Ntinda, we are very pleased to have you join us this morning for this fellowship. I thought I knew about cancer, but this discussion this morning has really enlightened me, not just about what I'm likely to face, but also what people I love, like, the gentleman's prostates, if not taken care of. So we are taking the call to really do early detection, to keep fit, and to support as much as Rotary through the different projects that we do to see that we are able to control and at the same time manage cancer. We really want to thank you, Diana and Professor Mansour, this morning for sparing your time and really doing justice to this topic. You have really expounded on so many things, and we are going to do our part, go to the sites that you have told us to go to be informed, and as well visit the different health centers that will help us to remain healthy so that we can continue being productive. Thank you. Health workers and practitioners are never thanked enough for the service that they give to our country. So we want to take this opportunity on behalf of Rotary to really thank you for the amazing work that you're doing, especially in this area of cancer. May you be richly rewarded. Thank you. And once again, if we do call upon you, we count that you will be able to join us. Thank you, Diana. Thank you, Professor Mansour. Stay well. Over to you, AP Caesar.
Yes, Sergeant at Arms, please.
President, I beg your indulgence. Can that lady of Agha Khan stay on call just after the fellowship? Thank you, President.
Sure, I'll have the Chimeza. Rotarian Ivan, Sergeant at Arms. Okay, I'll ask the Sergeant to post the attendance list in the chat in the interest of time, and also to allow a few minutes for our panelists to stay behind after for Chimeza. Amazing CP Mark, can you give us the final toast? CP Mark, are you there? Okay, can we have can we request AP Joy Ogang from Rotary E-Club Global to give us the final toast? Oh, where's everybody? Okay, Rotarian Bruce, it has landed on you. Rotarian Bruce from Ginger, can you give us the final toast?
Thank you, amazing President Caesar. And those who are served, could you charge your glasses as I give you Rotary?
The world.
Rotary
the world over.
To Rotary world
The
over.
world over.
World over.
Rotary world over.
Thank you very much. But we toast to
So,
Rotary.
Rotary
We don't give
Rotary
to
International.
Rotary. We say for the wonderful fellowship we have had, let us toast to Rotary International.
Ayogera ye CMP charity.
Yes, this is CMP charity. I graduated from the Rotary Institute. Correct.
You're very right. You're very right. You're very right. You're very right.
Is also correct, but in leadership, we criticize in private and then praise in public. We could go into inbox.
Okay. Can I have Rotarian Bruce and all comrades? Can I have your attention for a minute? If you could see, there is a little bit vibe in the chat. I have been able to share Diana Sewanyana's contacts for those that needed them. Then our professor has also shared a link to the online journals. I think he published them, and he's responding to some of our questions. Bruce, you asked the team to stay online. Is there any particular info you would want to know? Any questions that are burning?
Yes. Diana. You know, on Sunday we are having the cancer run. Are you coming to run?
That's a very good one. I have been invited to participate in the run, and I will definitely make the time.
Would you also get in touch with Rotarian Chove to buy at least 100 vests from him for the Agha Khan Hospital, please?
Sure, we'll get in touch with him.
Every vest goes for 25,000, and we'll be very glad to have the Agha Khan team running with us on Sunday also.
Godfrey, can I ask Professor a question, if you don't mind, please? Godfrey, with your permission, can I ask Professor Mansour a question?
Godfrey,
Can I also ask a question?
Professor Mansour.
Diana, before I leave, do you mind coming to Ginger? I give you a talk show on the radio tomorrow, Saturday.
We will arrange, we will definitely arrange, and we are doing everything possible within our means to reach out to as many Ugandans as possible. So if we definitely get in touch, we can arrange and organize and see how we can do the radio talk shows as well. Thank you so much for that offer.
Yeah, because you have given us that offer, so I'm giving you something. I can give you 2 talk shows every month. Come to the radio and talk.
Thank you.
People.
Thank you. We appreciate.
Professor Mansour, Bruce, can I ask a question, please?
Yeah, go ahead.
Professor Mansour, the dynamics of prostate cancer. What are the sticking out signs for a man to be aware of, so that they can detect any irregularities in their, day-to-day, so that they can actually schedule the PCA test? What would be the telltale signs, in your opinion?
So, there's a difference between prostate cancer and enlargement of the prostate that happens to all men when they go above the age of 55. When the prostate enlarges, which is a benign condition, it blocks the urine pathway. So men have difficulty voiding completely. You go to the bathroom very often. When you go to the bathroom, you cannot empty your bladder very quickly, empty your bladder completely. So you have to pass water frequently. But those are not signs of prostate cancer. Those are signs of what we call prostatic hypertrophy, a benign prostatic hypertrophy, BPH. Then there are men who have prostate infection, bladder infection, pain on urination. Those are not signs. So I would say rather than worrying about signs, one should just go and get a PSA test. And remember, when you have a PSA test, you have to be abstinent for at least 5 days. If you're not abstinent because of activity, the prostate gland will be activated and the PSA will rise. So I would say do not worry about symptoms. And if you go to the SES link that I gave you, it will give you signs of prostate cancer, signs of benign prostatic hypertrophy, signs of prostate infection. But more importantly, abstinence of 5 days and then get your PSA test. That's the best way to know whether you have prostate cancer or just a benign condition.
But what's the frequency of a PSA test? Should you do it annually?
Yeah, so initially, I think you're 50, you do at least 3 in a row every year. And then if they're all normal, you can go every 2 years. And I think the team in Kampala, AKU in Kampala, we have, prostate cancer months, breast cancer months, cervical cancer months. We have special subsidized rates for those tests on those particular months. And I think if you just keep up with the cycle, that can be very lucrative because they really are nearly at cost and very affordable. The main thing is, when you have the abnormality, what do? The trouble we have is we can provide PSAs at very low cost, but they're not following through is certainly the responsibility of the patient. And then they should go to the right person to be taken care of if there's an elevation of any of those markers, abnormal HPV test on the pap smear, abnormal mammogram, abnormal PSA. You then need to take responsibility and go to the right place, AKU or the other, to take care of it.
Bruce, muting. Sorry, Professor. Do you talk about costs of this, or you have to come for an initial consultation prior to determining the cost?
Diana, when we have those months, well, prostate cancer month, cervical cancer month, breast cancer month, we at AKU Nairobi post to say, by the way, we have now a subsidized rate because we're celebrating breast cancer month, so for mammography, etc. So I'm sure Diana and her team can provide that to the Rotarians. And we may well be able to say, by the way, if the Rotarians in a bulk would like to have a PSA testing done for their men, HPV for their women, mammogram for the women, etc. This could be arranged.
Maybe just to pick it up from Professor, just to address the question of cost, especially for those months, we have exactly the same approach in Uganda. When we are celebrating the cancer month, especially this happens in October, I see a bit of it in September. We do arrange with different organizations and subsidize the cost of these tests. So if Rotary Club Ntinda or Rotary Uganda would like to have these tests done, you can easily approach me. We work out a price that is favorable to you and we'll make it possible for you.
Oh, thank you, Dan. That's very helpful.
I have a question too.
Dr. Mansour, when is a good age to go for these tests?
The website I provided provides the age. I would say 50 is a cutoff for mammogram, PSA for sure. HPV, anybody who's sexually active should have a pap smear for HPV. So if you look at that website I sent you, it has specific ages for the specific cancers we're talking about. Yeah, makes it easier to review it.
Good morning, Dr. Mansour.
Good morning.
Yeah, I have a question here regarding how long. I have actually two questions. The first question is, how long does it really take for a cancer to metastasize when it's detected, from the time it's detected? And then the
And the second
second
one?
question is, what exactly happens to a patient who is declared cancer-free, and then after a while, the cancer is redetected and it's in an aggressive state? What happens during that time? Yeah.
So the time frame for metastasis is very different. You know, if you have a disease called leukemia, which is cancer of the bloodstream, we call doubling rate. The doubling rate of the cancer cell is hours. So within a few hours, you go from 1 cell to 2, 1,000 to 2,000, 10,000 to 20,000. So the doubling time. Doubling time of breast cancer, for example, is many months. So a tumor which is 1 centimeter may take 3 or 4 months to become 2 centimeters. But as it becomes 2 centimeters, it has a high risk of metastasizing. So, and there's no general answer. There are low-grade tumors, very slow, like skin cancer, which you have warts on your skin that become malignant, very slow doubling time. Blood cancers, very fast doubling time. Breast cancer, intermediate, months in terms of doubling time. Colon cancer, months of doubling time, which is why when you pick something up early, it is unlikely that they have spread depending upon the doubling time of the disease. So that's one. Number two, you know, cancer-free state is sort of a misnomer. For colon cancer, for example, if you have surgery, chemotherapy, etc., and at 5 years you've had no disease, unlikely that disease will come back. In breast cancer, even though you are cancer-free for 5 years, there may still cancer come back, either the same cancer that was quiescent now wakes up, but most likely the other breast has developed cancer as well, because you are at risk. There's some genetic instability in your body that predisposed you for the first cancer and now predisposes you for the second cancer. Thirdly, there are certain cancers which are hereditary. 10% of cancers are hereditary, familial. Angelina Jolie had breast cancer, her mother had breast cancer, her grandmother had breast cancer. They have the BRCA gene. So it is something that you spread through your progeny. So I think when cancers come back, it may be the same cancer because it was within the 5 years. And it's true, it may have metastasized and be more aggressive. Or it can maybe a second cancer. So I think that's a difficult question to answer, but an important discussion to have. I'm happy to stay for the next 10 minutes. At 8:30, I've got patients waiting, but I can stay for 10 more minutes if you have any questions.
Thank you. Okay, maybe I have one more question.
I also have a question.
All right, Juliet or whoever it is can go first.
Especially for when we talk about when you talk about the cancers that are hereditary, how are we able to prevent ourselves from getting them?
Right. So, you know, if something is hereditary, good looks are hereditary, bad looks are hereditary, cancer can be hereditary, 10% of cancers are hereditary. We have tests like, for example, Angelina Jolie has a BRCA gene that predisposes her to breast cancer, ovarian cancer. So what she did was remove her breast, get implants, remove her ovaries because she already had children, but it does not stop her for having spread that gene to her children. So we test the children. Today, if you have a bad gene for cancer, there are some ways to avoid that gene from becoming activated. So for example, now it gets a little bit complicated. If you have the BRCA gene, the Angelina Jolie gene, and your sister, it gets tested, and she has the BRCA gene, the risk of breast cancer is 70%. So she can then go ahead and have a breast removed, reconstructed, replaced with something else. So you protect yourself. You cannot change your genetic makeup. You got the gene, likely or badly, you inherited the gene. But we can help you remove the organs that may be the site where the gene will cause a cancer. In the future, we will be able to, with this genetic technology called CRISPR, be able to change the gene so that we reduce your risk, just like sickle cell. Sickle cell is a genetic disorder. A parent passes it on to their children. Today, we're able to change the gene for sickle cell in the young boy or girl who's born with this gene and correct the gene with CRISPR technology. So just wait. With time, we can do this. And I give a talk, and I was saying, if Rotary and Diana can work it out. I came to Kampala when I was a very young boy, when I was about 10 years old. I've not been to Kampala since. It's changed, I'm sure. You can invite me. The talk I gave in Vancouver a long time ago to Rotarians as well was, give me a drop of your blood and I will tell you your fortune. And it is true. I don't have to look at your hands and the palms and the little lines on your palms. With a drop of your blood, I can tell you the genetic makeup of your blood, your risk for cancer, your risk for heart disease, etc. That technology is coming your way. We need to be prepared for it so that this time, rather than having mammography, colonoscopy, PSA, just a drop of your blood can give us all the information. The trouble is, what if I take a drop of your blood and say, you're at risk for prostate cancer and you're feeling healthy and you're 35? Does that information cause mental distress, a mental health disorder? All those are ethical questions. Will the insurance say, I'm not going to insure you because your drop of blood predicts that you'll get prostate cancer? Those are ethical discussions and decisions that civil society and Rotarians will have to battle with. So more knowledge is good, but more knowledge also exposes you to other effects that we need to think about.
Thank you, Doctor.
Professor Mansour, I am a healthy person, but I want to consult with you. Is it something I can do spontaneously, or I have to go through intermediaries to get to you? How do I get to see Professor Mansour for all these initials? Is it something that can be done spontaneously with a booking consultation appointment?
Right. So we provide teleconsultations here to our patients as well as non-patients in Kenya. Through Diana, you can have a consultation with me in Nairobi, a consultation with a heart specialist, a diabetes specialist. Those are services we offer. Given the ability of Wi-Fi today, teleconsultation is available and Diana can set you up.
Okay, splendid. Thank you. Thank you very much.
One question, Dr. Mansour. Could you just comment about sugar and cancer? Because lately we are speaking a lot about lifestyle changes and talking about what is causing cancer, diet and nutrition, and sugar is coming up a lot. So I would like to know from your view and your perspective, how does sugar affect cancer?
Okay, so let me clear a myth, because a patient of mine, a young woman with breast cancer, was concerned about sugar. So let me explain how it came about. Normal cells have a receptor for insulin. Insulin is a hormone that controls your blood sugar. Tumor cells also have a receptor for insulin. So a receptor is like a mouth through which the tumor feeds itself. So there is a little mouth on the tumor, a microscopic mouth, where insulin goes in there, and insulin is a growth factor. So the thought was, if you have high blood sugar, your insulin level goes up in the body, and the insulin level now will feed the tumor because the tumor has an insulin receptor. So that was the theory. You would have to eat tons of sugar to be able to feed the receptor of your tumor. So that myth is not true. Obesity, now, too much sugar over a long time converts it to carbohydrates, converts it to fat. Obesity is a risk factor. Sugar per se is not. So too much sugar is not good for your teeth. You get caries. Too much sugar is not good for your heart because it will convert to carbohydrates and cause atherosclerotic heart disease. But sugar per se is not a growth factor for cancer at moderate rates. You can take an ice cream, take a good piece of cake, run it off next day, no problem.
Thank you.
Professor Mansour, diet. Sorry. What diet keeps you healthy personally? Because you're very knowledgeable. What keeps you healthy?
It's very simple: low fat, high fiber, and less red meat. If you pay attention to those three things, low fat, high fiber, less red meat, that is it. Now, you can't say you can't have a steak tomorrow. You can, but only in moderation. So just like Japanese have to take away from teriyaki and fried stuff, we here in Kenya have to, in East Africa, have to take less nyama choma, which is our favorite diet, more fish, more chicken, less fat, fewer Kentucky Fried Chicken visits, and exercise. And then when we in experiments in the lab exercise mice actively, their risk of cancer, when we expose them to cancer cells, they are protected. Clearly, there is something about endorphins, hormones that are created when you exercise that are cancer protective because they're, in a way, activate your T cells, your immune cells. So besides making you feel good, they also activate your immune cells. So that is one way why exercise is protective. But high fiber reduces the amount of toxins that stay in your gut. You poop them out, so high fiber is good. Low fat is good because it reduces obesity. And then exercise is good because of the endorphins. I'll take one more question if it's okay. And then I'll go and see my patients. But I'm welcome to come back. If you and Diana can work it out, I'll come back again on your station, come back to visit you and have a talk. But as I said, when I was a young boy in East Africa, I was born here. My grandfather used to give me 1 shilling to go to a Tarzan movie. And for that weekend, I felt like Tarzan. Come Monday, school came and I forgot about it. I don't want this session to be like one of those Tarzan episodes where you remember me, you remember my information for the day. Come tomorrow, it's forgotten. Nimisao. That would be a challenge. Yeah.
Absolutely.
So I want it not to be a Tarzan moment. That's got to be more, in a way, impactful.
Of course, we're inviting you more, Professor, through Diana. We'll arrange it. It's so much to take in and very, very hands-on information that you're giving us. We are absolutely appreciative of your efforts. Absolutely. Thank you so much.
I'll say goodbye and thank you, and I'm happy to come back anytime.
Thank you.
Diana,
Thank you, Professor, for the time.
Okay, take care. Bye-bye.
Thank you, Professor.
Okay, bye.
Bye.
Diana, that's very good. Thank you for your submissions. Those were very, very good. We do appreciate you spending time with us. Is it easy to reach you? Are there particular times we can make contact with you, or you're absolutely open to contact?
So I have shared my contact with Godfrey Chobe, and I think he will be able to share my numbers with you.
Yes,
Anybody
he
that
has.
would like to call me, I'm accessible all the time, even on Christmas. So anybody that is in need, please feel free to get my number, call me. And if you are interested in having Professor Mansour again, we're definitely available to bring him, either virtually or even physically. And just also to mention, we have another couple of very equally good professors in Agha Khan, Nairobi, that are very eager to share with you on any topic, even beyond cancer. If you want to talk about heart diseases, you want to talk about any other condition that might be bothering you, we are happy to host them. They're happy to come down here and meet with you if we make the arrangements.
Diane, things regarding, as you know, the risk factors you mentioned, you can see that a diet, nutrition and diet is very, very key. Can you line us some speakers who can demystify and simplify this whole nutrition and diet? We have Dr. Juliet is he's a specialist. Maybe we could do a panel session and really demystify aspects on diet and nutrition. Is that something we can do?
Sure, absolutely. We can arrange, as long as you tell me the dates, and we can pick an appropriate person again, and we make them available for this type of conversation.
Without a doubt, I'll reach out. My name is Robert. If I'll send you a text and introduce myself.
Sure.
Okay.
Sure. Thank you, Robert.
Diane,
Yes, sir.
do you understand Uganda?
Yes, I do.
Aga Khan hospitals are extremely expensive. Engeri y'ebisale by'essente biyimiridde bitya if I came to visit you at the Aga Khan? How expensive or how cheap will it be? I've visited the Aga Khan Hospital in Nairobi, and I paid through my nose.
That's a very genuine concern, and I think, Bruce, this is not only coming from you. We have been getting feedback from many of our customers, especially those that have gone to Aga Khan Nairobi. We have also aided a couple of people from Uganda to go to the Aga Khan Hospital in Nairobi. And I must tell you, it has not been necessarily cheap. I mean, it's not something that everybody can wake up and buy a ticket, get to Nairobi, get accommodation, get the treatment. It has not been coming so easy. And that is why, as the Aga Khan University Hospital, we have said no more. When we see what our people in Uganda go through to access healthcare, not only in Aga Khan, we've also seen those that have been going to India and in Germany. It is very, very costly. And as Aga Khan, we have decided to come and set up a similar facility, exactly like what you see in Aga Khan Hospital, Nairobi. That is what is coming to Uganda. And when we open up in Uganda, we are not maintaining the same costs as those you see in Nairobi. Why? Because we have taken about 7 years of feasibility studies just to understand the dynamics, especially in the areas of pricing, in the areas of access, and every other aspect that actually drives to somebody accessing healthcare. So we are bringing a service that is going to be a lot cheaper than what you have ever experienced in Nairobi or even in India. Now, coming down to the existing facilities in Uganda today,
Muting.
Muting.
Sorry, Diane, carry on.
Did you hear what I said?
Carry on. We had a minor interruption there. Sorry.
Yeah. So what we are saying here is we understand and we appreciate the concerns. We have taken the feedback regarding our pricing. And as of today, we have been trying our level best to ensure that we bring our prices to a level that is affordable within our clinics and within the upcoming hospital. You will definitely see, for those of you that have been visiting us lately, that our prices are beginning to go down because we are realizing that it's not accessible financially. So in terms of how accessible are we, or especially in terms of finances, we must say now that we're relatively competitive. If you look at other hospitals like Nakasero, we compare ourselves with IHK, we compare ourselves with AR, we clearly can see that in many aspects, we are beating them off in terms of price. And that is our vision, to make sure that the service is quality, yes, and yet accessible.
Dana, just a quick one.
Yes.
Yes, you've talked of affordability. It's one of the questions that has always been asked about the Agha Khan Foundation, because you're not for profit organization, but would expect your prices to be so way than any other place because you have in tax subsidies. Why isn't it you don't have like typically lower rates than anyone?
Very good question, Adrian. We appreciate that. It's I think in my earlier submission, that is what I was trying.
Adrian.
Sorry?
Go ahead, Dan.
Carry on.
So
ahead.
Adrian brings a very good question, and that is an area that we are focusing on as the Agha Khan University Hospital, even as we move and advance into opening up our hospital here. We have received the feedback, we have taken note of it, we have seen with our own eyes patients failing to meet their costs, and we have come in. And because we cannot consistently contribute towards the cost of care for some of the patients that we help, we are making a deliberate decision to bring our prices down in order for us to be financially accessible, especially in areas like cancer, in areas like cardiology care. We are competing very, very favorably with many of the not-for-profit institutions that we have in Uganda, and yet our focus is to even go lower than those that are already existing within the country. So Adrian, that's a very good concern, and we will continue to take it up. We will continue to work towards being affordable so we can serve you better.
Dan, what's your take when you look at the public health infrastructure of Uganda? I have a feeling that much of the service is centralized to more urban and developed parts of the country as compared to the rural. What is your honest take on the public health infrastructure? And I mean, largely many of the people in the rural part of Uganda will have all these risk factors, but will not be able to access medical care. Does the Agha Khan, and through your consultancies and all, what are the recommendations to the Ugandan government to improve service delivery? Is it something you engage in, or it's a far-fetched suggestion?
No, it is a genuine concern. It's a genuine question, and I get many people that ask me the same question. My personal opinion is especially regarding the public health facilities, is that there's a lot that has been done by the government of Uganda. We definitely appreciate the fact that the government has gone. But again, looking at the burden, the extent of the problem is so much larger than what just one institution can do. So for instance, if government has given us, in terms of cancer care, if they've given us Uganda Cancer Institute, they've gone ahead to decentralize the care of cancer by opening up other regional centers. We have heard about Gulu Regional Center for Cancer. We've heard about Lira coming up. Mbara is coming up. And all this is an effort that is being put in place by the government of Uganda to ensure that the people in the regions of Gulu and Mbarara can also access the same level of care that is possibly available in Mulago. From my personal point of view, that is an effort that is very, very highly appreciated, because we know that it is not easy. Working in the healthcare industry, we know for sure that anybody that is intending to set up a cancer center in Gulu and in Lira and in Soroti, it is not anything cheap. And we definitely appreciate the efforts that have been put in place by the government of Uganda. Now, beyond the government of Uganda, we also have the private players in place. And that is why Agha Khan is also coming into that particular space to say, look, government has done so much, but because the burden is so extensive, we can't just sit and wait for government to shoulder it all on their own. We need to come in and support and complement in areas that have not yet been reached. Our take on this as the Agha Khan University hospitals in Uganda is, once we are done with the opening up of our hospital in Akawa, we will also be spreading out into the regions of Gulu, Lira, Mbara, Soroti, so that the people in those areas can also access quality healthcare at an affordable price. It's an uphill task, but as Ugandans, we need to embrace it. We need to support every cause. We need to support the private partners. We need to support government to ensure that our people are helped.
Thank you very much, Diane. That was very, very elaborative. Thank you so much. Appreciate it. Bana, mwina ebibuuzo ebirala by'omukyala. Then I think if you have any prior engagements, Bruce, oinayo ekibuuzo?
Nze njagala mbuulire ddi lw'asobola okujja ejjinja ayogere ku radio.
Oh, Bruce, ekyo kirungi tweyanziza Mr. Bruce. Era singa kiba kisobose n'ofuna essimu yange, we can definitely discuss that. Tukisanyukira nnyo bwe tufuna abantu nga ggwe abagamba nti tuwaddeyo airtime abantu baffe bafune obubaka nga buno, kubanga gye bakoma okubufuna, gye bakoma okwekuuma, gye bakoma okugenda for early testing, gye bakoma okumanya kiki kye balina okwewala kubeera nti ebirwadde bino babyewala. So Bruce, tukisanyukira nnyo. Essimu yange Rotarian Choba agirina, asobola okugibawa ne tukola program ne tulaba ddi lwe tusobola okukola the same thing ejjinja.
Bruce, essimu ozirabye? Ziizo ozirabye?
Essimu nzirabye.
Ziwandiike.
Anytime, Diana, any Saturday you want to come in, come. From 10 p.m.
Barbara, you have a question. You had your hand up.
No, I just wanted to say thank you so much to Diana. Thank you. You know, when we finally have a Ugandan who can communicate in a language that we understand, explain cancer very simply. And also, I know he's already left, but thanks to Professor Monsu. I mean, what they have done, I think this should be recorded and shared because they have simplified a very, very complex subject. I just wanted her to know that we really appreciate.
And he also mentioned that Professor said that we can reach out as much as we can. So we really have a silver bullet here. Because it's really intense. Even to be a health, it is just so overwhelming. Diana, webale nnyo bambi webalire ddala oba kansubye tetukusibye obudde bwo webale nnyo obutuweeredde ddala tweyanziza nnyo nnyabo.
Thank you so much.
Do you have any other questions? The 26 members on call, or we could let Diana go and carry on with that day.
AOB, Diana.
Yes, sir.
Oli mufumbo.
Yes, sir.
Oh, abaana bameka.
Bangi kose.
Diana,
Bruce, wandimubuuza bubuuza oba aliibwako. Bruce, mubuuza oba aliibwako.
Diana, are you a Rotarian?
Sorry, Diana, my question, I'm driving, sorry. Do you have a health insurance with Agha Khan? And someone buys health insurance?
Okay, so most of the insurance companies that we're working with, those that are locally available, are the ones that are supporting our patients. And that includes UAP, Jubilee Insurance, AR, Sanlam, Liberty, CIC, Bupa, Vambreda, East African Underwriters, literally all of them. I mean, we have 100% coverage for the insurance companies in Uganda.
Diane, what other what things would you love, because we want to invite you more, what topics of passion would you want to talk about, given your experience having studied the public health sector in Uganda? What salient areas would you want to talk about a bit more?
Waliwo kyatazeemu ekya okubeera Rotarian.
It's several city Rotarian.
We would love you to join Rotary so that they can hear more of you. It's a very big network. We would love to. Can we engage you more on the subject of Rotary on a personal level? Absolutely.
Sure.
But what are you studying? What key areas, passion of discussion?
What we have observed and what we consistently see in the healthcare industry that is really bothering most of our people, number one has been cancer. If you want to broadly categorize the issues, we categorize them as the non-communicable diseases. That includes the cancers, it includes the diabetes, high blood pressures. Now we are having cardiovascular diseases. We're having the genetically inherited diseases like Professor mentioned, sickle cells. Those are the areas that are really pertinent to us. And anything that we possibly can do in that area, we are happy to do it.
Paige, I think this is the point at which we...
Oh, Dr. Juliet, sorry, Bambi, unmute yourself. So sorry about
No, I was just saying, sorry, I kind of muted. No, I was saying, I think this is the point at which you say we need a platform for us to have a group of speakers. And I think, Diana, this is an opportunity for us to have something on this non-communicable diseases, because it's a big problem. And I think there's a lot that can be done, and people need to be empowered. Just like you talked about the public health situation in Uganda, there's a lot that the Ministry of Health is doing. There's a lot that the health system is trying to do, but the health system is not just made of the healthcare system. It's made of the human resources. It's made up of we, the people, the beneficiaries of the healthcare. So we need to empower people to take care of themselves, to self-manage themselves, to prevent these illnesses. And I think that's a key message that we should be looking at as well.
Dr. J and Diane, we can set this up, and should we have a discussion, an in-depth discussion?
Sure.
I agree.
Sure, we should.
Okay, that's something we're going to set up ASAP. Because Dr.
Thank you so much, Rotarians.
We are going to engage you, Diana. People need to hear you talk, especially on non-communicable, all these communicable and non-communicable diseases with Dr. J. People have to learn. Some of these things are, the risk factors are there, but many of these things are really associated with behavioral characteristics and traits, so they can be avoided. So if people learn better dietary and health and management, we could avoid so many of these catastrophes in our personal lives.
Sure.
Dan, thank you so much. We'll reach out.
Thank you so much. Have a good day.
Have a lovely weekend. Muchkin. Bana mwebale nnyo. It was a wonderful fellowship.
Ped. Robert, I was in another meeting, but I've been following closely. And thank you so much, Diane. And please send my regards Rotary Club Agendas regards Professor Mansour. It's been a very beautiful and engaging conversation and a bit insightful.
She's off.
Chobe tuwejaze zaffe.
Charity or on call. Can you please come and respond to that questions? I want to manja jaze and koi.
Mokole refine.
Good morning.
But just to bring it to your attention, jazes were returned to be fixed. Unfortunately, I kept demanding for the jazes until a one myriad in Nigeria who is on this platform offered to go and pick them physically. We had disappointment. I had paid again for these errors to be rectified. She reached there and no work was touched. After all these weeks, we have been demanding for something where a client, there is nothing has been done.
Let them just return them the way they are. It's okay.
Yeah, she picked them. They are currently with Nigeria. She has offered to contribute 50,000, and we saw someone else, a different supplier, who is going to rectify all the mistakes. Personally, I had also offered 100,000 because I was involved into the whole process. Now, the new person we have identified is requesting for 250. 2 people so far, we have 150. Hopefully we could get another person, or probably one by one. Anyone could send in a 10K quickly, and we have them fixed. The guy has promised us a week or 2, maximum 14 days, to have them well branded and with the right name and spellings of the word Rotary and Club. So I apologize for any inconveniences, most especially to those people that in the diaspora, because they expected to travel with their jerseys and we could not meet a deadline. I am working closely with Myriad. I have not brought it to the attention of the whole clubbers team because I felt it is something we could fix backdoor and give you, I don't know, that is it from me, but kindly bear and extend us fortnights.
Put for us.
Sure we
Yes,
sir.
Chicho chagenda wrong ne jerseys. Good wording yalimbi.
Yeah, they were mixed up. The sizes were different. Rasanga Caesar, who is putting on XL, Kawesa, who puts on small, and then the word Rotary was misspelled. E-Club Mutinda, the logo was not seen. Like the branding was 100% or 120% wrong. And it is not something I would pride myself, because there are people who would comfortably take them and send them, but as the PR, I feel like I'm sending the wrong message out there. If I cannot brand myself properly, then what kind of message am I sending to the society? I recalled them back, took them back to the service provider, who was meant to fix it in 4 days. We agreed that she even asked for a top-up, which I paid instant. Unfortunately, a month later, I kept on demanding. Charity is aware of this conversation because I think she sourced out the service provider. I will keep demanding for them. The stories were, I am delivering on Friday, give me up to 4 p.m., let me send my border guy, and all that. Sylvia calls it halabalu. But it was a little bit disappointing and frustrating, most especially when you wake up to people who will call you every day. There is a one Sarah Danilo I know. Every time she sees you, whether you are where she keeps saying, my and is late. So
branding very important.
Yeah,
very important.
So kindly allow us a fortnight. Good enough. There is someone who has offered. I am also offering something. If there is anyone who feels like, it is because right now it is a collective responsibility. If there is anyone who has anything, just reach out to me to fix this. Because equally, I'm not in the best, financial situation right now. But I could appreciate any support that comes from any of you. Thank you. I hope that clarifies the situation.
And how much is spending on that repair? You said?
No, so far we have 150. It's 100,000 pending.
Bruce.
Sebo.
Charity abuziza mu gundi ani yakuzaala. Obuziza ekibuuzo ne tuddukayo emisinde.
Abuziza ekibuuzo
ndiki. Who born you? Charity abuziza who born you?
Kyakibuziza ddi?
Kiri mu chat room. Ani yakuzaala.
Namaganda nga sinaba mulaba.
Who born you?
Charito lirudawa nga sinaba kugiraba message ene lirudawa.
Wansi wa Barbara ja forwardinze eyagundi who born Rotarian booster now. Tajirabi.
Nze ndabye nkomye ku wano we bali ogamba nti
omukyalo omubuuza ki oba mufumbo obibuuza wano ku forum.
Gwe. Kirina okutereezebwa kumanya if it is eatable or
My goodness, yo, Bruce, wefuge.
You wait when she comes to ginger.
Watch your mouth.
Agenda kujja.
Bana Doreen, hello Doreen. Sarah, Obama morning. Bruce.
Ani Sarah Namilo.
Morning.
Sarah, nsonyiwa mukwano wambuza ekibuuzo saddamu. I don't know whether you got all the information you needed. I am so sorry, Nerabira. Did you get it?
Yes, I did. Thank you.
Okay.
Good morning, Ped. Naye obadde wagundi, obadde obuze nnyo.
Nga tonnoonyaako mu inbox nga gyendi.
Mukwano.
Yeah, bakunoonyaako.
Nze nkyali disorganized.
Uli otya? Wasanga waka oli watya?
Wanjigiriza okubuuza mu lulimi lwammwe naye
disorganized.
Nampiseeko.
How are the kids?
The kids are fine, thank you.
Mr. ali atya naye?
Oli otya?
Nze am
Mr. naye mulungi.
Sirina wannuma at all.
Nkuwulira.
I am good.
Tokiwulidde nga kigezaako okugamba dokita nti I am healthy. I'm healthy. Gendayo bakupime
ngambye we are healthy. Naye kati omanyi akamwa kano katonzi olina okweproperinga ng'oli healthy.
Kyekyo.
Bw'ogamba Diana, I'm unhealthy ng'olwo oguddewo enzigi za unhealthy.
Ng'oguddewo ekigwo.
Ng'okubyewo kasita okifulumya mu kamwako ng'omubiri gwo responding immediately.
Enkoona eba enywedde.
So you propel good health, you propel positivity, you propel kitegeera.
Ng'obadde mu Uganda naali tuyise no encouraginga abavubuka mu church.
Jinja nandibadde mu butuufu madde nja kulya mulokonyi naye era nja kutuukako.
Mwana.
How was Ginger?
Ginger is fantastic. Last week ente yange emu yagudde.
Omukyala ali atya? Mwakomawo bulungi okuva South Africa?
Twakomawo gwera kuddayo nga 13.
Any positivity?
Yeah, changes are there. Yeah, we hope by 14th ajja kuba ali waddeko.
Tomutulugunya kubanga bakuwadde go ahead omukyala muleke ya?
Of course.
Muzo okutandika okwagala
Sara baba tebamuka. Achali tebamanyi kutambula n'abaana paka mu DCA. Abaana muleta baki mu DCA.
Bayiga empisa zammwe embi mwagala kugwira
ekyo nga kyakuluma nnyo. Ekyo nga kyakuyisa bubi.
Atambula ne family namba yonna.
Baagala nnyini okusumbuwa abantu.
Okulya enswa z'abalala.
Chove.
Alright, Maka.
Maka alabika yasimagiriddeyo.
Omanyi winter etandise okuyingirayo.